Okay, Assalamu alaikum and good evening. We are back again after a gap of 3 months on the 40th edition of the Conceptual Basis of Urology course. This evening, we are very fortunate that we have Mr. Zishan Aslam, consultant urologist in Fife, Scotland. We have Dr. Zubair Chima from Lahore, both known experts in the area of kidney cancer. And we're going to talk about metastatic kidney cancer. We'll start off with few cases, and then we move on to a little presentation. Okay, right. You can see the first slide. This is a 61-year-old male who first presented in September 2020 with generalized weakness. He's a known diabetic, which he was very poorly controlled. Only remarkable thing was a microdiscectomy that he had about 12, 13 years back. Got an ultrasound in Quetta, which showed a right renal mass, subsequently had a CT scan. I don't have a CT scan, but this is my operating room notes picture that I have just pasted here. And it was about 7 centimeter upper polar predominantly mass with some cystic areas and central necrosis. So we did a radical nephrectomy because the CT scan didn't show any extra renal disease. It was an open through flank incision. There was significant neovascularization with Gerota's fascia, and the perinephric fascia was quite closely adherent to the tumor. He made an unremarkable recovery. On 4th postoperative day, he was discharged. This is his histopathology report. It was a T3A NX tumor, clear cell renal cell carcinoma with grade 2, according to the new classification system. And the tumor was invading the perinephric fat. Otherwise, all the other resection margins were negative. He subsequently had another follow-up in 3 months' time, and at 3 months follow-up, he was clinically doing well. His workup indicated, again, poor control of diabetes with sugars raised. His creatinine was normal, so he underwent a CT scan, which, barring a simple cyst in the contralateral kidney, didn't show anything else. So CT cap was essentially unremarkable. The next follow-up was about 6 months from surgery. And again, nothing much in this CT scan as well. And then after that 6-month follow-up, he somehow ended up with an oncologist. At that time, his creatinine was 1.3, although our radiology is quite happy to do a CT contrast at 1.3. But for some odd reason, he was advised a PET scan. So any comments, Zishan, on the choice of PET scan in this scenario? Normal, more or less, our normal range is 1.2 milligrams per deciliter. His creatinine was 1.3, and his CT scan 3 months earlier, you have just seen. So would you still do a CT on him, or would you do anything else?
Prof, obviously from getting the findings point of view, nobody would refuse PET scan, but looking at the creatinine, it's a marginal rise, which we would expect in a post-nephrectomy patient. And clearly, yeah, it's a good question, comment by Abdul Wase, what was the EGFR? But I wouldn't expect it to be too desperately low. So I think CT would be absolutely fine here with regards to contrast exposure.
Yeah, but somehow he ended up having a PET scan. And the PET scan was also pretty much unremarkable. So, but then he was lost to follow. And he presented about 1.5 years later no active symptom with a raised creatinine. But now what we see on the CT scan, his renal bed is clear. His liver seems to be all right. There are some nodules. I don't know if my marker is visible. Is the arrow visible on the screen?
Yes, visible.
Yes, it is.
Yes, Prof.
So there is a lesion here, as you can see clearly, and then there is another big paratracheal lymph node, and this is a pretty big nodal mass that he has in the chest. So his creatinine at this time was normal. He underwent a biopsy of this paratracheal nodal mass. And the biopsy result indicated that this is indeed metastatic carcinoma with clear cell features. And now he has metastatic clear cell carcinoma with a suspicious lung lesion, which looks very, very suspicious, and obviously a significantly large paratracheal nodal mass. So, Zubair, what would you take him to the tumor board at this point in time? You would have any other views on this patient?
Yes. Hi, Prof. Yeah, I agree with you. Obviously, we'll take it to the tumor board to have a joint discussion with our oncology and radiology colleagues. Just going back to the way he presented with his renal mass, which looked aggressive perioperatively, as well as on his initial histology, he had a tumor necrosis, as well as, if I'm right, it was T3A. So it was a high risk disease, even in the hindsight. Although it seems that he did reasonably well for 1.5 or 2 years without having mets. But eventually, when he presented 2 years down the line, he does have that suspicious looking lung, possibly met, and this biopsy proven enlarged lymph node, which is paratracheal and looks like a tricky position in terms of its anatomy. So I think the discussion probably in the MDT will revolve around 2 points. Obviously, if these are the only 2 sites, are they technically amenable to removal, if by any chance? And maybe the cardiothoracic surgeons may guide on that, or if not, or going through the rest of the scan, it looks that it's pretty bad, or it's a tricky location, then are we looking at some kind of a systemic therapy?
Yeah, the case was discussed in the tumor board, and precisely this was the discussion that the paratracheal lymph node is quite resectable. It's away from the hilum of the lung, and it can be removed. We don't know about whether it will be R0 resection, but the lung nodule will be a little difficult to localize, but still it seems like a surgically removable. So the discussion was on this line, and somehow the discussion then focused on the use of systemic therapy, because it seems that there was a loss of window period of nearly 1.5 years between his last follow-up and this presentation. So there is very likely possibility that may have some systemic disease besides the one that we are seeing at the moment. Zishan, what would your tumor board suggest in this situation?
Yes, Prof. Clearly, as you both have mentioned, both options are there, surgical as well as systemic treatment. He is, if I recall, he is still in his youngish age group, 40s, 50s.
Yeah,
yes. Yeah, so which means he would be fit for that as well. But I would be slightly more inclined towards systemic treatment, not just because of the delay, but I just feel whether complete tumor excision would be complete removal of all the metastasis would be possible, considering the extent and two-site metastasis in a way. I mean, it's all in respiratory system, but again, it's more than one site. So I would be slightly more inclined towards SAT, systemic anti-cancer treatment. Yeah.
Great, fine. I have a few more cases, but I think I'll let Dr. Anika present her case, and then we will see if we have time. I have about 3 more cases, but I would be more inclined towards letting her present first. So I'm unsharing. Are you ready to share?
Yes, sir.
Proceed.
Is my screen visible?
Yes.
So, I will presenting a case of metastatic renal cell cancer, and we have been following this patient for last 2 years, and it was one of those challenging cases of renal cell cancer. So this is a case of 67-year-old gentleman who is known case of hypertension, ECOG status 1, ex-smoker, and he initially presented to orthopedic clinic in June 2021. And at that time, he had the right leg pain, and he has a history of repetitive falls and difficulty in walking. So, in examination, he has antalgic gait, and his past medical and surgical history was unremarkable, except that he had TURP and he was taking antihypertensives. So, all of his baseline lab workup at that time was within normal range. His SP was 13.4 and the creatinine was 1.0. So, based on this history, orthopedic surgeon got done his X-ray femur AP and lateral view, and we can see that. Just a minute. So we can see that is my arrow visible. So we can see that there is this radiolucency and the cortical irregularity. So based on this X-ray, the orthopedic surgeon did the curettage of that lesion and then the intramedullary nailing. So this is the post-IM nailing scan, and the biopsy of that lesions came out to be metastatic renal cell cancer. So then orthopedic surgeon referred him to the urology clinic with the CT scan, chest, abdomen, pelvis with IV contrast. And these are the CT scan images. So here we can see that this is the lower pole mass of around 6 to 7 centimeter, well circumscribed, heterogeneous, and it's visible on the axial and coronal images. And there is this nodule, the pleural nodule at the right upper lung nodule, and it is around the 5 millimeter. So based on this CT scan, patient was given both the options of, but initially he was advised, we were more inclined toward the systemic therapy because he had a bit poor functional status and he had oligometastatic disease. So, but he had like financial restriction from the start. So based on this CT scan, we got his baseline lab workup, and all of his baseline lab workup was within normal range, except that he had the platelets of 533 and he had the poor performance status of 80%. So my patient has the intermediate risk disease according to IMDC risk factor classification. And we all are aware of these risk factors, prognostic risk factor, and the 0 factor indicate the favorable risk disease and the 1 to 2 factors indicate the intermediate risk disease. So based on this intermediate risk disease, the patient has the median overall survival of 22.5 months. And according to EAU guidelines, we cannot offer cytoreductive nephrectomy to the poor risk patient, but we can offer cytoreductive nephrectomy to some of the intermediate risk patient based on the number of the meds and based on the patient performance status. This case was then discussed in the tumor board meeting, and cytoreductive nephrectomy was done in July 2021. We had given the option of systemic immunotherapy, but he had the financial restriction. So the tumor board agreed on the decision of cytoreductive nephrectomy. Meanwhile, we were waiting for the immunotherapy. So it was a 8 to 9 centimeter right lower pole renal mass, and the adrenal gland was spared. But on histopathology, the adrenal gland was involved by the tumor. It was T4 disease. One of the lymph node was removed, but it was negative. So after this cytoreductive nephrectomy, patient was then following in the oncology clinic, and he was kept following through the PET scan, and even we are aware of that the PET scan is not the ideal imaging, but the oncology team was following that. So this is the first PET scan, and there was no PET scan done prior to the even the cytoreductive nephrectomy, and we can see that there is this nodule around 6 to 7 millimeter at the nephrectomy bed, and with SUV max of 4.5. And on the coronal images, we can see that there is this left suprarenal nodule of around 20 to 22, 23 to 22 millimeter with SUV max. And there is this FDG avid uptake at the femur area, but this of the lung nodule was non-FDG avid on the PET scan. So based on this PET scan, again immunotherapy option was given, but he had the financial issues. He was from Balochistan, so he couldn't get the financial clearance from that. But he had the persistent leg pain, so he was following in the orthopedic clinic, and orthopedic doctor advised the radiation. So he received the radiation to right leg that ended in February 2022, and after that his pain was better, and he was then started the pezopene because he had to came all the way from another province, so he wanted to have something oral and something cheaper. So he was started on the pezopene, and that was started from the March up till June, and he was then advised to follow up in the June 2022. Injection denosumab was also started. So this is the June CT scan. So the oncology team got on the CT scan at that time. Here we can see that this left suprarenal lesion, which is now slightly increased in size up to 24 to 25 millimeter. And there is this hypodense area at the tail of the pancreas, which according to radiologists could be the metastatic deposit. So based on this CT scan, they labeled it as the progressive disease, and he was then followed in the oncology after the CT scan, and immunotherapy, combination immunotherapy, the treatment of choice for the metastatic RCC patient, the combination therapy was started, axitinib, 5 mg BID, and the pembrolizumab. So that was started in June 2022 after the CT scan, and up till April 2023. After that, the axitinib dose was increased, and the pembrolizumab, he received the 12 doses of pembrolizumab up till the April, and in April 2022 he had the follow-up with imaging which shows the disease progression. He had another imaging PET scan in the December during this immunotherapy combination, and that was showing the stable disease. And he also reported certain side effects with the immunotherapy, which include the drug includes hypothyroidism and the GI upset, and that was managed conservatively. So according to EAU guidelines, the intermediate risk patient also can receive the the combination therapy, and this is now the era of the combination treatment, like the one TKI and the one checkpoint inhibitor, and we can also give the two checkpoint inhibitor like nivolumab and the ipilimumab. So my patient was started on the pembro and the axitinib. So he had the follow-up in the April, and this is the follow-up PET scan. Here we can see that this left suprarenal region, and by that time the right sided deposit came non-FDG avid, and the lung lesion was non-FDG avid since the start. But we were following, the oncology was following this left suprarenal region, and now it has increased in size from 22, 24 to 42 to 36 millimeter, even on the combination immunotherapy. So he was advised to continue Pembro 16 doses till July 23, and axitinib was also on continue, and he was advised to follow up in August with the imaging. And this is the August scan. Here we can see that the left suprarenal nodule, and now it has increased in size up to 45 to 60 millimeter. And this patient was then given the option of left suprarenal metastatectomy, and it was a 5 to 4 centimeter left suprarenal lesion, and the left adrenal gland was above the lesion with the clear demarcation. So it was a left suprarenal metastatectomy, and the histopathology came out to be metastatic clear cell RCC, and the margins were negative from the adrenal gland. So post-operatively, he had the stable recovery, he had the complaint of vertigo and the dizziness, and the MRI brain was done, which came out to be normal. He had 17 doses of pembrolizumab in October 2023, and then he was advised to follow up in November. He had follow-up in November in oncology clinic, and it was now showing that there is no recurrence or no residual disease in the adrenal or any of the abdominal or the chest region, but it's still there is this FTG avid uptake in the right femur, and he had the IM nailing in place. So in summary, it was oligometastatic intermediate risk disease for which cytoreductive nephrectomy was done. That was followed by surveillance. And then the TKI was advised and followed by the combination immunotherapy and then the left suprarenal metacytectomy. So what do we have options for the femur mets? So we gave the radiotherapy for the bone mets. He never had any brain mets, and we gave the tyrosine kinase inhibitor, and we did the metacytectomy, and we gave the combination immunotherapy. But now there is this role of stereotactic ablative radiotherapy, and I was reviewing the literature, and there was this meta-analysis where 54 studies were included, and stereotactic ablative radiotherapy has a very good result in the local control rate. And this meta-analysis include all the studies of the primary, metastatic, oligometastatic, and so there is this now era of stereotactic ablative radiotherapy. I also want to generate a discussion if do we have any second line therapy, because my patient has received the combination therapy, so what else we can offer to him. So that is it. Thank you.
Thank you very much, Anika. I think I'll ask our experts, Dr. Zubair first, and then Dr. Zishan. I think there were a couple of points where a decision could have gone one way or the other. So this gentleman initially presented with metastatic disease to the bone, which is relatively unusual, but we probably have seen everything with RCC. So, and at that time, he didn't have any abdominal imaging. So because the probably the orthopod didn't thought of as a metastatic disease. So subsequently, you know the story. So at point after the orthopedic procedure, Dr. Zubair, with a lung lesion, which is small and suspicious, not very clearly metastatic, and isolated small volume kidney, which is obviously the primary, would you have considered systemic therapy at that point, or would you have gone the way it was done in this case?
All right. I think quite an interesting case, and the whole journey of the patient has been quite interesting. As you said, when he presented with a leg issue and a bony met, and a scan showed a renal mass along with possible chest met, and he fell into the intermediate risk group. I mean, this intermediate risk group can be quite tricky, and some of those patients end up having a long discussion in our MDTs, like which way do they need to go? Depends upon the patient fitness as well. I mean, bone mets, we don't see them, I think, upfront as a presentation in many of these cases. So if they are bone mets, generally we think this probably is a bad disease. And if he's falling into the intermediate risk category in the current era of immunotherapy, and if those resources are available, having said that they may not be available at all the places, then one of the inclination could be going towards systemic therapy first to see how it responds. And that theory that since there's a lot of antigens with that cancer still present in the system, and the immune therapy may respond well to those patients. And then if they behave well, then you go and take the disease out. I have a feeling that I might be, if I was at that stage, might be more inclined towards that. Yes. If we don't have those options available, then I think what you have done is the right thing. This is one of those things which could have gone either way.
Thanks. Zishan, any further observations on this issue?
Yes, Prof. I think I totally agree what Zubair has said, that the whole, I think, debate when it comes to cytoreductive is, including Carmina, Certime trials, they all mostly revolve around intermediate risk disease. We know the low risk and high risk one way or the other. So that's where I think it has someone presenting with the bony metastatic disease, which in olden days was against the indication for cytoreductive, and then having another potential met, which likely was a metastasis considering the overall scenario. Then I think starting with systemic treatment would be a preferred option, and then getting the disease under control. At that time, it's more and more advocated to introduce cytoreductive nephrectomy at that point, once the disease is controlled. But yeah, presenting with a pathological fracture, which again is a reasonably volume disease, could be a more towards starting with systemic anti-cancer treatment. But whatever the path was followed after that, I think it was the right decisions regarding post-cytoreductive SAC, and then moving on to adrenalectomy at that point, because the mass was growing, not responding.
Great. I think the delegates and audience must have seen that decision-making in the current era is not easy. It is becoming more difficult when the options are available. In the era when we had very limited options, cytoreductive nephrectomy was the mainstay of management of metastatic kidney cancer. So take this through, I have a little presentation that I'm going to share with you for the next 20 minutes. And in this, we're going to talk a little bit about the role of cytoreductive nephrectomy in the current era of systemic therapy. So if you look at the statistics in United States and UK, the overall numbers may vary because of the population, but barring that, there is the proportion of kidney cancer per 100,000 population is pretty much the same in UK and United States, which is 64 cases. I was recently in a meeting in SARC, Association of Urological Surgeons, and I've shared this data, Globocan data. The proportion of patients, 5-year prevalence, 100,000 population, is quite low in our part of the world. And I think this is not a true reflection of actual disease. It is probably because of the poor collection of data that we have and lack of registries in our part of the world. One interesting observation that we all know is that between 1975 and 2014, and this is SEER database analysis, the number of cases per 100,000 population has doubled, more than doubled during this period. We are diagnosing more cases. I mean, diagnosing more cases, we are obviously diagnosing more localized cases and small renal masses. However, if you look at the statistics, the number of patients dying from renal cell carcinoma has not changed. It is pretty much the same. Over 14,000 patients dying from kidney cancer, which is 1975 and 2014, pretty much the same. And the reason is that we still see significant proportion of patients presenting with metastatic cancer. So this is European data, Capitanio, and 17% of patients harboring distant metastases at the time of diagnosis. And about 1/3 of the patients who have been initially diagnosed with kidney cancer ultimately do develop metastatic cancer. So at any given point in time, there is a significant burden of metastatic kidney cancer. The metastatic kidney cancer, as you know, would either be metachronous, which means the case that we have discussed in the first case that I've described, in which the patient initially had an organ-confined disease or localized disease. As Dr. Chima pointed out, that there were some indicators showing that this patient has a potential for developing a systemic disease. And no sooner there was some slackness on the part of the patient in his follow-up, we found that he ended up having a metastatic cancer. But this group has relatively better prognosis compared to those presents with synchronous metastatic cancer. So in this Checkmate 214 study, the survival difference is double. So patients with synchronous metastatic cancer would survive for 24 months, and their cohort, the survival for all of the patients was twice as much. Now, systemic treatment, if I look at my own personal history, and I see that I was working with in Rotterdam with Gerhard Mikisch, who was one of the 6 people at that time. I'm talking about early 90s, and this is the unit at that time headed by Fritz Schroeder, the famous ERSPC gentleman. So at that time, the only thing that we had was high-dose interleukin-2 interferon alpha. And since Gerhard Mikisch was one of the 6 people in Europe who were credentialed to give high-dose IL-2, I actually seen these patients admitted in ICU, highly toxic treatment, and unfortunately, the outcomes were not very promising. So this is early 90s. During the same time, we were able to identify the von Hippel-Lindau gene by the 2 pathologists from Sweden, I believe, von Hippel and Dr. Lindau. And it was many years later that it was identified as one of the putative mechanism by which wild type and genetically determined renal cell cancers develop in patients with a VHL mutation in chromosome 3, I believe, a short arm of chromosome 3. But this opened up a new era of systemic treatment in which we developed targeted therapy based upon our understanding of the VHL gene mutation, and its downstream pathways. However, still our outcomes were not amazing, and we were nowhere close to what medical oncologists have achieved for most metastatic diseases using chemotherapeutic agent. So we're still about close to 20% improvement in survival with systemic therapy using the targeted therapy. From there on, we were able to identify the programmed death and programmed death ligand 1 and its potential role in renal cell carcinoma and some of the other cancers like ovarian cancer, etc. And that ushered us into the era of PD-L1 or immune checkpoint inhibitor and immune oncology times. And now we are now entering into the era of combination therapy using immuno-oncology or immuno-oncology and TKI. So what is, if any, there is a role of cytoreductive nephrectomy? So starting from the time of the Robert Flanagan study, SWOG study from US, interferon alpha, same time Gerhard Mikisch's work in Europe, the EORTC's trial, again indicating that interferon alpha with cytoreductive nephrectomy or alone, the patients who have a cytoreductive nephrectomy has a slight advantage. So at that cytokine period, cytoreductive nephrectomy still had a role. Lara, who subsequently looked at Flanagan's data with a longish follow-up, still could see that there is a survival benefit using the cytoreductive nephrectomy group patients. We entered into the target therapy era, and it was presumed that maybe the cytoreductive nephrectomy role would decrease and systemic therapy will take care. Unfortunately, it didn't happen. The retrospective study by Shoeri and colleagues and Hana's work and Rousel, and Silagis all have shown that cytoreductive nephrectomy arm has a significant survival advantage compared to the arm which only receives systemic therapy. However, these are two landmark trials, the Carbina and the SOTIME trial, which tilted the balance out of the surgeon's hand towards more systemic therapy regimes. We'll talk about these two trials and briefly. We know some of the criticism to these trials as well. Now, we have moved from the targeted therapy to the immune checkpoint or immuno-oncology era with a lot of very, very significant trials. And you know, most of these have shown a significant advantage of systemic therapy compared to the type of systemic therapy that we have used in the last 30 years. The Cytokick, Nordic Sun, and Probe trial are some of the upcoming trials, which actually looks at the timing of cytoreductive nephrectomy, not excluding cytoreductive nephrectomy as an option. There are criticism to Carbina trial. We all know that these are some of the shortcomings that we have discussed previously as well. And I think Zishan also presented on a very similar note in this conceptual based course, talking about some of the limitations of Carbina and SOTIME trial. I'm not going to go into this again. The SOTIME trial again was very poor accrual, and it could not really achieve its set targets. In fact, the Independent Data Monitoring Committee suggested that rather than the progression-free survival, they should use a 4-month progression-free period as the endpoint. And this trial was essentially looking at the timing of cytoreductive nephrectomy, whether delayed cytoreductive nephrectomy or upfront. Important thing to see is that even in the immune checkpoint inhibitors era, the number of patients or the percentage of patients in the group in these studies was small. So patients who did not have cytoreductive nephrectomy was highest in the Checkmate 9ER by Motzer, published in New England Journal of Medicine in 2007. And there were about 30% patients who didn't have cytoreductive nephrectomy. But barring that, all other trials, and these are very famous trials, the Javelin, the Checkmate, and the CLEAR trial, they all have between 80 to 70% patients who did not, who had cytoreductive nephrectomy. So cytoreductive nephrectomy continue to play an important role even in the era of systemic therapy. Now, this is what Zubair alluded to earlier, and I think this is a very important point, and this is for our residents to really understand that in the current times, we are not looking at the role of cytoreductive nephrectomy, but more of the timing of cytoreductive nephrectomy. Obviously, not every patient can have or will have a cytoreductive nephrectomy, but those who are eligible based upon the current understanding. So essentially, the current focus of treatment is that when a patient is naive of treatment, that is, didn't have any surgical treatment, this patient has a patient-specific mutations, a significant immunological load of antigens. And if you hit this patient initially with immuno-oncological agent, these new class of immuno-oncological agents is going to identify the targets by the antigens presenting. And based upon this, it will mount a more global antigen response, antibody response to these mutations. So it will more globally have a more holistic sort of response to the tumor. And once you have hit with the systemic therapy, you can then take care of the load of those mutational load which are not likely to respond to the systemic therapy by doing a cytoreductive nephrectomy. So I think our focus is now moving towards doing a delayed cytoreductive nephrectomy rather than an upfront cytoreductive nephrectomy. So one of the concern that as most of us are surgeons, and the concern is that, well, if the patient has received a systemic therapy, is he or she a good candidate for surgical extirpation? The SURTIME trial using sunitinib, the PROSPER trial using nivolumab, the neoadjuvant ICI trial with exitinib and ipilimumab, all these trials have shown the safety of cytoreductive nephrectomy without significantly increasing the morbidity of the surgical procedure using these agents. So surgery can be performed once the patient has had a little washout period after receiving the last dose of systemic therapy. These are some of the upcoming trials. And when I looked at this article, this is about 6-8 months old article, most of these trials were still recruiting patients into the study. But what you see is this: all these trials have cytoreductive nephrectomy as an important arm of treatment as an intervention. So cytoreductive nephrectomy is not going to go away soon. This is the PROBE trial. The proposal was published last year in Kidney Cancer Journal, and essentially looking at asking the same question. The hypothesis is that cytoreductive nephrectomy, if performed as a delayed intervention, is more likely to work because of the broader antigen load and the chances that the immune checkpoint inhibitors will work better if they have a wider load of antigens. What about and this is all this data is for clear cell carcinoma, because all the trials have actually excluded almost completely or to a greater extent the non-clear cell cancers. The SWOG 8949, which is the Robert Flanagan study, the EORTC 0930947, which is the McIsh study, Carmina and SURTIME trial, have excluded. If you look at the SIA database, cytoreductive nephrectomy still play a significant role and improves survival from the SIA database reported in European Urology Focus recently, in which the 2 years mortality rate was 52.6% in comparison to 78% in patients who had cytoreductive nephrectomy. Very similar thing was noted from the IMDC database analysis of non-CCRCC patients, that the cytoreductive nephrectomy does provide a median overall survival advantage in the group which had cytoreductive nephrectomy. Now, there is one important aspect that we need to really look at, and this is particularly important for us. It is becoming important for the West even, is that the cancer-related spending in 2018 United States was $156 billion. This is half of the total GDP of Pakistan, which stands at something like $310 or $320 billion. So, and the greatest contributors to this spending was in medical supplies and non-physician services like anti-neoplastic agents. The per cycle cost of Nivo and Ipi is $21,000. And for exitinib and pembrolizumab, what our patient received was $27,000 per cycle of. Patient who are on these agents, not only there is a cost related to the medication and administration, but also managing complication. So this paper by Watson, published in JAMA Network actually, and they looked at that patients who receive nivolumab and Ipi have about $2,000 to $3,000 for managing their complications, and those who were on exitinib and pembrolizumab about $3,500 to $5,500. So it is a very expensive option, something that only insurance or government-sponsored patients can afford. So what cytoreductive nephrectomy can potentially offer is that patient can defer further systemic therapy if cytoreductive nephrectomy is performed, because their overall tumor burden will be much lesser if cytoreductive nephrectomy is performed, and they may avoid further treatment and decrease the cost of care. So in summary, the role of cytoreductive nephrectomy has evolved over the past few decades, from the time of standard practice in the prior to 90s. Then once we have the systemic therapy with IL-2 and interferon alpha, to nowadays with immune checkpoint inhibitors and immuno-oncology era. But cytoreductive nephrectomy still has indication. It has an indication in a setup where patient has a low volume with favorable risk metastatic RCC, patient who do not require immediate systemic therapy, again, is a group which can have a cytoreductive nephrectomy. Patient who have favorable or intermediate risk factor who respond to systemic therapy with stable or regressive disease may consider delayed cytoreductive nephrectomy and avoid using further systemic therapy. And obviously, patients who have had symptomatic kidney cancer with bleeding, pain, and some of the problems, quality of life can be improved by cytoreductive nephrectomy. So my message to the urologist is that although we have entered on a systemic therapy era, still a knife has some role, or your laparoscope have some role in this setup. Thank you very much. And I would really request our audience to ask questions, and please post them on your chat box. And I would request Zishan and then Zubair to comment or observation that they have. Please. Zishan, would you like to go first?
Yes, Prof. Just a couple of comments, if I may, please. I mean, with Carmina trial, clearly the two groups, intermediate and high risk. So high risk, it has made it even more clear, it's not the cytoreductive. The controversy regarding the intermediate risk, which we have been historically doing as well, surgeries on, that was further clarified in another 1 year's time at the next American Society of Clinical Oncology meeting. And I think Anika did mention briefly about that, where they had identified a subgroup with a single factor intermediate risk group, like all those 5-6 factors, if it's only involving one factor and only one metastatic site. So those groups were the ones who had intermediate risk do well, and that's why we still continue to do cytoreductives for intermediate risk disease, even in setups with not much cost issue. And the second thing with regards to post systemic treatment cytoreductive, and again I would just really echo what you have suggested, that this is something, despite the certain trial was not so well powered, this is something which again is taking a lot of place in the current management in UK, where after having a good disease control, we just move on to perform the surgery. And this has been encouraged a lot by the oncologists. Like in the last 6-7 years, in a moderate volume centers, not a high volume centers, I did 5-6 cytoreductives every year. But in the last 1 year, I've done about 4 cases of such cases where we do the delayed systemic treatment and reserve the systemic treatment just for any further recurrence. Prof, I think you're mute.
Zubair, any comments, observations?
All right. I think it's been brilliant discussion. The one thing, as you alluded, is the horizon of this immune therapy and cancer treatment for metastatic prostate cancer is evolving, and it's ever changing over the last decade or so. So I think more and more things are going to come up. The second thing which I will emphasize, as you said, was that the key thing is probably in that intermediate group is the timing of the cytoreductive nephrectomy. The cytoreductive nephrectomy, as once we thought, probably is going out of window after those couple of trials, but it will remain there in some form and shape. It will just probably will take where exactly in the journey of a patient we need to do it. That may vary from case to case base, and as more evidence will gather, probably as Zishan mentioned, we will get more clearance on that. But the key point will be the timing of that.
Yeah, I think I agree with both of you. So this is important, and I think for our audience, and the whole idea of this deliberation is to clarify situations. It is always difficult to make decisions when you are actually taking care of the patient with all the limitations that we have in our setup. But still, the current management of cancer, and be it any cancer, urological or non-urological, the collective decision-making, a collective wisdom use is the key in essence. There are rapidly changing scenarios, their availability of newer drug regimens, new way of treating these patients. So it's extremely important that we should have the tumor board discussion, utilizing the wisdom of all those individuals sitting in that group. If there are any questions or any observation from any of the colleagues, we still have about 6 minutes. So please feel free to raise your hand or write in the chat box, and Sharif will allow you to speak. So, Mazhar, you have any observations? Would you like to say something?
Well, thanks very much. I think the most important thing, as everyone is alluded, whatever decision we are making should be patient-centered. There will always be a role of cytoreductive nephrectomy, but the cost need to be amplified that what you want to achieve for your patient, isn't it? There's no point doing an aggressive surgery and making patient worse. But I think as Prof has mentioned, patient-centered, and you should have cancer board meetings and stratify based on the patient factor and disease factor. So thank you.
I see Dr. Faiz's iPhone 13. Is it Professor Faiz Mumtaz?
Hello, Ahmad. Greetings from London.
Thank you very much.
I saw the
I
webinar.
suspected it would be you. We can't have a discussion on kidney cancer without Faiz Mumtaz.
No, not at all. I thoroughly enjoyed the talk and very constructive points. Very comprehensive talk, I must say. Alluded to everything. I'm not sure what I can add here other than what you guys have alluded to, but I enjoyed the talk.
Thank you very much. So there's a question from Dr. Amar. If there is no response on immuno-oncology or combination therapy, then what is the ideal time? And is there any role of cytoreductive nephrectomy then? If there is, then what is the survival benefit? Now this question is, Zishan, would you like to take this question?
Yeah, so basically we have tried immunotherapy, combination therapy, and I'm presuming you mean first line, second line, whatever the options are ran out. Then the role of cytoreductive nephrectomy, it all, I would say, depends on what exactly is the tumor metastatic load. If it's a really high volume multi-organ metastasis, then I'm not too sure whether cytoreductive nephrectomy would have improved, would have survival benefit in that case. It could be done in a palliative setting if patient is a big mass and that has been bothering the patient. The ideal time, I think probably an oncologist might be able to answer this better, but again, they do try like after first line, second line, or third line before they just ask us for consideration of the surgery. I'm not sure whether I answered your question fully.
No, I think I agree with that. The treatment is very much individualized because really depends upon the patient's functional status, the tumor burden, what are your goals, what you want to achieve out of the whole situation, whether he or she is likely to benefit from second line TKI or immunological combination, or if there are symptoms related to a kidney tumor, what quality of life is a main consideration, etc. And I think one more important thing is the emerging role of stereotactic ablative radiation therapy, which is something that can be used at least for brain and bone mats. And they are obviously much less intensive, and they probably would be able to achieve some improvement in survival. And some retrospective work has shown this. So this is another thing in your armamentarium that can be used. So if there are no more questions, I think we can conclude our conceptual base course for this evening. Hope to see you again the last Saturday of December. We will probably may change the dates because of the holiday times. So I will keep you posted the exact date of the next conceptual base of urology course. Thank you very much for being here this evening, and have a very good weekend.
Thank you very much.
Thank you very much, everybody.